Hello, everybody. Welcome to a new episode of the Dissenter. I'm your host, Ricardo Lopes, and today I'm joined by Dr. Kristen Syme. She is Research Associate at the Faculty of Behavioral and Movement Sciences at Vrije Universiteit Amsterdam. And today we're going to talk about mental disorders from an anthropological perspective, focusing mostly on suicidal behavior. So, Dr. Syme, welcome to the show. It's a pleasure to have you.
Hi, Ricardo. Thank you for having me.
Okay, great. So, this is interesting that we're going to talk about mental disorders from an anthropological perspective because it seems that it isn't the case that people across different societies and cultures think about mental disorders in the same way, right?
Yes, that's right. So mental disorders are a product of, the Western medical paradigm. So, yeah, you wouldn't expect them to exist in other cultures necessarily.
Yeah. Okay, so, but are there other cultures that also have a concept that is similar to mental disorder?
So there's obviously variation across cultures. So many cultures have words for madness, being crazy, something we'd probably tend to associate with psychosis, having psychotic episodes, which overlaps but is not the same as schizophrenia or, maybe more extreme like bipolar syndromes. Um, but, some people, there are words for, different aspects of depression, things that we call depression or grief or, reactions to stressful life events. But those, the word depression doesn't actually directly translate into most languages because it's a direct consequence of actually Western philosophy and the writings of Hippocrates. And so when we look across cultures, we actually find that rather than having this sort of general abstract concept of depression that's extracted from life events, so the DSM doesn't include anything about, what caused the depression, except for, the fact that it used to, if you were suffering grief, it didn't apply to you, although that has changed. In other languages, there are terms for, you might talk about lassitude or withdrawal or, having suicidal thoughts, but they're associated with specific relationships or specific social interactions and not with this sort of more abstracted general concept of depression that occurs inside of individuals.
But people who exhibit these kinds of behaviors that in the West we would classify as some sort of mental disorder, do they have some social stigma associated with them in other cultures, particularly the more traditional ones, for example, hunter-gatherers and so on?
Yeah, so again, there's quite a bit of variation. So Roy Richard Grinker is an anthropologist, and he's looked at, he actually has two really great examples. It's also hard to assess this across cultures because it tends to be rare. And so it would be hard to have a research team assess enough individuals across, small scale societies to get the numbers we'd need to do that kind of testing. But there are great anecdotal examples, and that's often what we have from the ethnographic record, are case studies. So among the Johansi, or also known as the San or Kung of the Kalahari Desert, he discussed two individuals. One individual who is exhibiting psychosis and likely was actually diagnosed by medical personnel as having schizophrenia and was receiving treatment for that. So he actually wasn't stigmatized by his local community, although they were wary about him, because he was, he would exhibit sort of frightening, aggressive behaviors at times. But it was never, a moral issue or like there's something wrong with him. They actually thought it was because of sorcery, that because somebody is actually the fault of somebody else. So somebody in his camp offended somebody in another camp. Somebody in that other camp had sent, a sorcery attack, and the spirits fell inside of him and now he has madness, and the spirits, talk to him sometimes. And so it has nothing to do with him as an individual. It's not the same way we think about stigma in our culture. So he was getting treatment, pharmaceutical treatment, and he was also married and had children and was still integrated in that society, which is obviously different than what you might see in a lot of urban settings where those people are homeless or institutionalized. And another example he gives is somebody is like a younger man who is exhibiting what is probably autism, but high functioning autism. And he's sort of peculiar and he gets teased, but he's not stigmatized in any way. He's a fully functioning member of the group. So yes, they recognize that he's weird, he's peculiar, but not that he's diseased. And so yeah, the disease concepts of the concept of pathology doesn't apply in either case.
Mm-hmm. Does it have something to do with the fact that perhaps in some of these societies there are certain roles that can be occupied by these sort of people? I don't know. For example, one thing that comes to mind is that people who would suffer from things like schizophrenia could be shamans, for example.
Yeah, so it's hard to say because in many contexts, so psychosis is a continuum. So people who don't have schizophrenia can experience psychosis to greater or lesser extent, or to have fewer or more episodes. And then there's full-blown schizophrenia, which is it's chronic, reoccurring psychosis. So even people who have like PTSD or stress reactions, depending on what terminology you prefer, they can also have episodes that look like psychosis. And so there is because also in a lot of cultures they value vision quests or the visionary experience, which to some, the naive psychiatrists might want to call that psychosis. It's not, though. It's actually intentionally induced hallucinations through like fasting and drug use and trance states. So there is some overlap. So we don't want to confuse, these sort of visionary experiences with psychosis, although there is, it's really ambiguous and fuzzy. And also people with severe schizophrenia really suffer in social relationships. Now, this can be exacerbated because of circumstances of the modern world where people are more out on their own rather than being integrated into a social group. There are a lot of people who vehemently say that no, schizophrenia, they would not have been shamans. Like that's, you're romanticizing schizophrenia because it really has horrible consequences for people. And they actually they suffer from, interpersonal, deficits. And actually, in small scale societies, shamans often function, they're typically knowledgeable, and they often serve a role in resolving conflicts. So you'd have to have pretty good interpersonal skills. So it's hard to say. There could be, maybe, but I think the evidence suggests no, and it's probably a confusion between these more like visionary trance-like states and, schizophrenia and the deficits that come with it.
Mm-hmm. Can we say then that the concept of mental disorder is a cultural construct?
That's an interesting question because to some extent, everything is a culture. You can say anything is a cultural construct because it's based on, language and communication. So biology itself is like a cultural construct because we gain that knowledge through the educational system. We transmit that knowledge through language. So yeah, all of medicine is cultural. Cancer is a cultural construct, but how well do they approximate the underlying reality and what can we do with those models of the world? And so it's just a model of the world that approximates reality, just like every other aspect of science, basically, and medicine. And so but the problem is that unlike other, disease states like cancer, like heart disease, we can't identify like an exact biological mechanism that we know is causal, that this is, we can find differences in brain imaging technologies, for instance, in fMRI scans, but difference doesn't mean disease, right? So really what we're talking about and looking at the history of mental illness as a construct is just behaviors that are undesirable and that have been medicalized. And so a lot of what has been defined by psychiatry as a disease has been social deviance. Now, some of what is categorized as a mental disorder is perhaps a true disorder, meaning that it represents a dysfunction of an adaptation. Potentially the case with schizophrenia, that there are potentially some deficits in interpersonal cognitive function involved, so being able to understand the mental states of others. There may be genuine deficits, so dysfunctioning adaptations, as opposed to just, this is behavior we don't like. On the other hand, there are some states that are, like homosexuality, for instance, was, for a long time, considered a pathology. And it kind of, if you understand the context of American culture, where you're expected to grow up, reproduce, mate and reproduce, and have like the typical American family, you can kind of imagine, okay, I can see why in that context you might see homosexuality as a kind of a dysfunction, because you're not wanting to do the thing everyone is expecting you to do. And actually it took people who were themselves homosexual becoming psychologists and really making this an issue that it ended up being reversed. So that shows how, cultural values and sociocultural processes really play a role in how we define what is an illness.
Mm-hmm. Could it be that some of the mental illnesses we classify as such in our modern industrialized societies, they simply correspond to behaviors that are not really adapted to the kinds of conditions we live in now?
Yeah. So are you trying to get at the concept of mismatch? So in the way that we evolved, maybe our modern environment is so removed from the environment in which we are adapted that new conditions are arising. Is that what you mean?
Not exactly. I was not talking exactly about evolutionary mismatch, but maybe, someone behaves in ways that doesn't allow them to function properly in our modern societies, and so then people, mental health professionals, classify that as some sort of mental illness.
Yeah, so to some extent, the values of a society which is rooted in, to some extent, their technology and their economy, if you go against that, if you don't fit into that value system and that economic system, whether you yourself are suffering from a disease, yeah, you might be classified, you might be stigmatized, identified as being problematic. That can be, again, because of genuine illnesses that you're not able to take part in the society, but also just because, for instance, if you're not, going back again to Roy Richard Grinker's work, he talks a lot about how in capitalism, if you're not an efficient worker, you can be seen as being, you're problematic, right? And that's actually how we identify ourselves, is by, for better or worse, and whether we, this is something I actually try to actively fight against all the time, but it's hard when you're embedded in that sort of world, not to define yourself by the products of your labor, or as a laborer, or as someone who does this, to contribute to the economy or to science or to what have you. And so that's actually pretty much all mental illness categories involve people who are somehow not fitting in to that system. Depression in particular, in order to get businesses to fund depression research, what they'll often do is talk about how much money is lost every year, which is in, the billions of dollars, like $80 billion or something, that is lost because workers are either depressed and they're not showing up to work, or they're showing up to work depressed and they're not being efficient workers. But then when you look at it, you find, like when you dig into the data and you do research, you find that actually what people are reporting is that the reason they're depressed is because of bullying in the workplace, because they're not being compensated for the work that they're giving. Basically not being, feeling exploited, essentially. As another example, there was actually a time in the American Civil War period when runaway slaves were categorized as being mentally ill, because it was thought that to justify enslavement, people would say, oh, that's just, they would classify it as like a race thing. Well, that's just because they're a subordinate race and they're actually happier. They should be happier as slaves. And so, so they have these arguments to convince themselves that they're doing a good thing by having slavery. And then when slaves try to run away, which, nowadays, like, that makes sense, that you would try to escape. They have to now classify that as, well, that doesn't fit our model of how slaves should behave. So now we have to pathologize that. We have to say that identify that as something that we need to solve about that person, rather than looking to, say, the system, the social system or the economic system that is just making people, naturally not everyone's going to fit into an economic system for one reason or another. It could be because of certain aspects of personality or, normal variation. So we think about, the classroom setting. It's hard to imagine what ADHD or hyperactive attention disorder would be outside of a classroom setting or a work setting.
Right.
What would even the problem be? Because when you look at read ethnographies about hunter-gatherer societies, they spend a lot of time, now obviously you have to humans have to pay attention to their environment. But it's hard to imagine what would be wrong when they're usually spending all day learning in play groups and they're outside. Why would it be what would hyperactivity even look like without, being in a classroom, that structural setting and having a teacher, trying to keep everybody in line? It's hard to say.
Mm-hmm. So, but I mean, we can perhaps people sometimes classify something, a cluster of behaviors as a mental illness to stigmatize people because they want to say basically that they are not adapted to the sorts of conditions we live in. But I mean, nowadays also many times people want to attribute the status of mental illness to a particular set of behaviors to try to elicit compassion, for example.
Yeah, so that's the flip side of that. So once, it's interesting because, once these categories exist, so you can stigmatize them, or maybe you can, venerate them, or, which is why people are concerned about like romanticizing schizophrenia. You can build compassion, but that could be paternalism. It's still reinforcing that something is wrong. In some cases there really might not be something wrong, or when in the case of schizophrenia, it looks like it really like immigration and urbanization seems to really worsen symptoms. There's some evidence for that, and so it's still putting it on the individual, that there's something wrong with them, and not necessarily the context and the wider, social circumstances that are also contributing to that condition.
Mm-hmm. So perhaps we will get into the definitional aspects of this question, but are mental disorders diseases?
So I like to use Wakefield's harmful dysfunction concept, which is an illness concept, which is a way of defining disease, because to some extent, there's sort of two camps. There's the constructivist camp, which will say all diseases are simply constructs. And then there's more the naturalist camp, and they'll say, no, it's all diseases are truly biological. But Jerome Wakefield, he recognizes both, and that's what I like about it. That to some extent, deafness, for instance, or being blind. So these are adaptations that are clearly dysfunctioning. But you can create a world, and we have pretty much created a world where you can be blind or be deaf and be a fully functioning member of society. So you can have that dysfunction, but it's not harmful to you because we've created a society where you can be a fully functioning member. On the other hand, you can have like ADHD that might be harmful because you're not fitting into the society, but it's not a disease. You can kind of compare it to cosmetic surgery. So maybe if you're in LA and you're part of a certain social sect and I don't know, if you want to pursue, acting or, being a celebrity, you have to look a certain way. So you might feel like, if your nose is too long or your ears are too big, you have to get surgery. But again, maybe it's harmful, but there's no disease, right? So the harmful dysfunction concept is that there has to be a truly underlying dysfunction, and it has to be harmful. So deafness, in the modern, so it might classify in small scale societies where they're not able to build the sort of resources we have and the infrastructure that they can be fully integrated. So maybe in that context, it would be a disease because it would have an impact on your survivability. But in a modern society, it wouldn't have to be a disease. So it's contextual. And the same is true for mental disorders. So, ADHD is an example, and depression is also. So if we think about, it might be harmful because you're not being a fully functioning member of your society. It's affecting your ability to generate income. But the evidence in this case actually points to it's not a dysfunction, it's an adaptation. And so it would be wrong to call it a disease and potentially exploitative. On the other hand, schizophrenia, bipolar, these might be genuine diseases. Autism, if you're on the lower functioning, that involves intellectual deficits, those could be genuine dysfunction. Those could be genuine diseases.
Mm-hmm. So now talking specifically about suicidal behavior, what is the best way to understand it from an evolutionary perspective?
Well, I think the first way to think about it, when we talk about evolutionary, an evolutionary perspective, we really want to, pinpoint adaptation. So what might the adaptation be? And to do that, we actually have to look at the phenomenon, and we have to really carve out what it is. So there's this tendency to think about suicidality and think about suicide death, which is the most extreme form of suicidality. But most suicidality is actually non-fatal suicidal behavior, which includes ideation, threats of suicide, and suicide attempts. And this isn't an artifact of modernization, actually, not an artifact of, being near hospitals. So for instance, for women aged around 20, there are 100 suicide attempts for every one suicide death. In Papua New Guinea, there's one society where the anthropologists actually collected data on suicide attempts to suicide death. And it was like 2 to 1, and probably more, because people actually, surprisingly, people often forget about suicide attempts, and we can talk about why that might be. But interestingly, in their minds, I'm talking about the people in Papua New Guinea, they thought suicide death was more common because it's just, that traumatic to a group if someone dies by suicide. And so but even in that context, they're not near medical facilities. Suicide attempts still outnumber suicide deaths. And so when we talk about using from an evolutionary perspective, we've probably early theories about it have, and actually ongoing theories about it are probably misguided by focusing on the death aspect and not the ideational and the attempt aspect, because that's where suicidality really lies.
But when you said that, what was it? That people forget suicide attempts, were you only referring to people who attempt suicide or also the people around them?
So it seems like there's some research that shows that people would be admitted for suicide attempt and they'll like forget about it. But people will also just forget about like hospitalization. Like they'll forget when they were hospitalized for something. And so I don't have any hard data on that. It's a really interesting, phenomenon. It could be, so not to jump ahead, but one thing, our data, our cross-cultural data shows that suicidality is very often preceded by conflict. And so if those conflicts resolved and if those conflicts are forgotten, it could be that the suicide attempt is just forgotten because things are better now and, they don't revisit it in their minds.
Mm-hmm. So suicide attempts are usually preceded by conflict.
Yeah, and that's true. So that's what we found in our in the human relations area files. So I collected me and Ed Hagen collected every case or cultural model of suicidality in the human relations area files. We limited data analysis to the probability samples, which is a stratified random sample of cultures. And what is it, about 90 or more % of cultures, some kind of conflict was identified as preceding suicidality. And then, you go into even the Western layer. And so that's across stratified random sample of cultures, diverse cultures, cultures that don't typically make it into, cross-national data on suicide. So it's things like, loss of romantic relationships, forced marriage is a big one for women. Actually, we haven't published on this yet, and I'm sort of just waiting for the opportunity to. But we found that for females, forced marriage was exclusively associated with females, and loss of status was almost exclusively associated with males as the events that triggered suicidality.
Mm-hmm. And do we know why, at least I think that's what the data indicate, why males tend to commit more acts of suicide or suicide attempts than females?
So actually males, and this varies a little bit across societies. And again, this is not captured. So a lot of the cross-national data is biased towards urban settings. When you look across cultures, especially small-scale cultures, so we find cross-nationally, most suicide deaths are males, but actually most suicide attempts are females.
Okay.
Yeah. And so actually going back to those same numbers in the US, so it was 100 to 1 for females about age 20. For males about age 20, it's 10 to 1. So there's 10 suicide attempts for every 1 suicide death.
Right. But do we know where those differences come from?
It's no, honestly. So, and it's interesting because, and so again, there's variation. So where I started doing field work in Micronesia, so suicide death, it's actually, so yes, there's already a male bias, but in Micronesia, which is where they tend to be matrilineal and matrilocal. And females, they don't have, men still have more power, but females also have quite a bit of power as well. it's, yeah, like there's one female suicide death for 11. In the US, it's like 2 to 1. It's not that extreme. But I'm actually hoping to begin doing research with Turkish communities in the Netherlands, migrant communities. Outside urban settings, most suicide death and most suicide attempts appear to be female. And so these differences appear to be related to the culture, social structures, conditions in their environment, but we really don't know. So it's an open question. So females tend to, for females, it tends to be things related to forced, mating, forced sex, rape, forced marriage. That's what female suicidality tends to be associated with. Because, it's a lack of choice in mating that affects female reproductive success. For males, their reproductive success is more constrained by status. And so it looks like, so it's actually fitting, the sex differences in suicide and what causes suicide actually fit with an evolutionary picture of what constrains their reproductive success. And so exactly what the social dynamics that cause, high rates of suicidality in females in one society, but it's males in another society, that's an open question.
Mm-hmm. Do we know if the reasons people give to attempt suicide, of course, the ones who survive, are similar to those kinds of causes that you're pointing to?
Yeah, so it's hard because there's not a lot of, people are really reluctant to ask people those questions. So to do, it would require doing semi-structured interviews on suicide attempts. It's hard to recruit people for that kind of research. I've been trying to do that for a couple of years. It's hard to even get it off the ground. It's hard to get ethics approval. It's hard so I've been working with that Micronesian community for several years. And I started asking about parent-child conflict, which in that society is linked to suicidality. But as an outsider, I can't just, or even as an insider, or just anybody, you can't walk around being asking people casually to talk about that, to take part in an interview, even if you're, assure them that everything's confidential. People just aren't jumping off their feet to do it. And there's a lot of stigma tied to it too. And so I'll be trying to do that, in the next year, 2 years, with the Turkish community in the Netherlands. That's also going to be a challenge to just get people to even talk about that, to be willing to take part in that kind of interview. But there is some data, and I know people who have done that research. And so someone Diana van Bergen, she's here in the Netherlands at the University of Groningen. She did interviews with migrants from Morocco, India, and Turkey. And it's a small sample size. I don't think it was more than, something like 20 interviews, 30 interviews, but in-depth interviews. So common themes were entrapment, feeling powerless, feeling like you can't help yourself. So that should be true. We actually would expect that to be true for both men and women, that you are genuinely powerless, because you wouldn't resort to suicidality unless you really had no other choice. It wouldn't be your first option, right? That makes no sense. So whatever, you would have to be your absolute last resort. So some of the examples that she found, so for instance, one woman was, actually 2 of them involved rape, or at least 2 of them, probably more, involved rape, not being believed. And it was someone sort of actually both cases, it was either a family member or a brother-in-law, and just people not taking the girl's side, or just blaming her. And so yeah, that does fit with the picture. I'm not aware of anything that looks at where they've done semi-structured interviews with males, but from what I've seen, but they have done, I have seen some where they interview the family members afterwards. So the person had died, but they're interviewing the family members. So a psychological autopsy, where they interview family members to try to find out what was going on in the mind of the person. And yeah, it looks like things related to status. So something Diana Van Bergen has mentioned to me is when she's done some interviews with or psychological autopsies regarding male suicides, it's things, related to status. They're not, maybe they, in the Netherlands, around the age of 12, and this is true. I think maybe it's true all throughout Europe. You're sort of set on a path of, okay, you're going to go to university, you're going to go to a technical school, you're going to, be a laborer or something. And so people can be really affected by where they end up falling into that system. And so she's reported that people that in that case, there are stories of males who maybe they were hoping to get one thing, but they ended up in sort of the lower status path. And that was related to their suicidality. In Micronesia, it looks like, so status can be, there are several ways men gain status. One way is through being competitive and aggressive. Another way is through, education, gaining status politically. And so, again, if they're not getting sort of investment from people, if they're feeling like they're not being valued to be on that path to having the status that they want, that seems to be related to some suicides there as well.
Mm-hmm. But there are also individual differences in how much people are predisposed towards suicide, right?
Yeah, so there are, it's hard to say because you'd really have to look at people who were in the same situation. Because it wouldn't even necessarily be like you're exposed to the same kind of adversity. So maybe with depression that might work, or PTSD. But with suicidality, so it's really about, it's not just the adversity, but it's the powerlessness. It's the ability to escape the adversity. It's the ability to rally others to help you to escape. Because, in the West, we typically think of suicide as being responsible. Individuals are responsible for themselves, and people who are suicidal are also responsible for themselves. We can sort of forget the fact that we are interconnected and we are nothing without, our social groups, our social networks. And we often do need help from others, either because we're being exploited by other people and we need someone else's help to get out of it, or maybe even the people who care about us are exploiting us and we're trying to communicate them that there's a conflict of interest, but they don't see it. And so, you'd have to look at people in the same kind of situation, and then seeing what about their social network. So just because maybe two people were exposed to sexual assault, one of them was believed and they got help. And actually, there is, I think, some data supporting this. I think Randy Thornhill's work on rape actually supports this. Maybe it was depression and not suicidality, but women who were believed and who got help and they didn't feel like they were under threat, their psychological well-being was better than those who weren't, not surprisingly. So yeah, it's looking at multiple factors.
Mm-hmm. So probably you've already touched a little bit on this, but tell us about the bargaining model of suicidal behavior and also the inclusive fitness model. And perhaps, I'm not sure if the evidence supports one more than the other. Tell us about it.
So the bargaining model, which I've sort of been touching on a little bit, is you're facing a fitness threat. Mm-hmm. And you are powerless to escape that. And you're in conflict with others who, they would help you, but they don't believe you, or they don't recognize the conflict because maybe they think you have an incentive to lie, or they have an incentive to exploit you, like as often the case of like forced marriage, for instance. And so you need to send a signal that a costly signal to say, this is how much I value. So the one way to frame it is like, this is how much I value my circumstances. I don't value, I don't value it. It's not worth being alive if you're going to force me to marry this person, or if you're going to force me to be in these circumstances. And then, so in the case of a forced marriage, for instance, well, people should react, people should be like, oh, okay, we didn't, we value, you're a valuable member of our group. Obviously we're going to, they might have been benefiting from a marriage, so they obviously don't want you, they want you alive. And so it's sort of, that's why it's called the bargaining model. Another way to put it would be like blackmail, but that sort of has a negative connotation. But if you think about it strategically, it's not like, manipulation in the way it's often used, like you're just trying to exploit somebody. It's like, no, this is an honest signal of need that you have to send in order to not be exploited and to increase your fitness. And so it's really an honest signal of how they perceive their own fitness.
Mm-hmm. Right, and the inclusive fitness model.
And so this was developed by Dennis de Catanzaro. And so, we're all trying to improve, that's the goal of evolution, if you want to frame it that way, increase your inclusive fitness. So the inclusive fitness model of suicidality is that your fitness would be increased if you actually had died, because you are, according to this model, you have low reproductive potential, so you're not able to reproduce. And you are, maybe you have some crippling disease, or you're not able to contribute to a group such that you are a genuine actual burden on the group. And so you'd actually increase your inclusive fitness through death. And there are cases of inclusive fitness in the animal kingdom. We see that with certain species of wasps and bees. So there are sterile castes who will sacrifice themselves for group defense. It has to do with the unique genetic makeup of those colonies. There are also, you think of like the black widow male spider, he's after copulation, he's eaten, and that increases his fitness, because his calories to the mother are, go to the offspring. It's not clear. I mean, it doesn't look like that is true in humans, because we actually didn't find too much evidence for it in the ethnographic record, even in places where you would expect it, or where they even have cultural models very similar to the inclusive fitness model. So in the Arctic, for instance, in many Arctic and subarctic populations, it's an extremely harsh environment. It's not every man pulls his own weight exactly, but you generally need to be like a contributing, functioning member, because resources are scarce. And so they do have, senilicide, so ritualized killing of older people who are no longer contributing, and sort of like a suicide of those individuals. And it sort of varies by group how that looks. But in those instances, it's often sort of a suicide homicide. It's in many cases, the person actually has to say okay, I will, die now, or whatever it is they say. And once you say it, you can't go back. It's taken very seriously. And oftentimes somebody close to you will have to do it. So in one case, it's like strangulation is sort of the method. And it has to be someone close to you. And it's an agreement. It's, everyone, it's highly regulated and ritualized. And so it's not just something you can do. But that's not suicidality as we typically are talking about it. That's that's homicide suicide. And so if we did have this adaptation similar to wasps, similar to, what we see in insects or arachnids, it's a mechanism that acts in a certain context. And there's not this, this weird, there's an event and it happens, but that's not what we see in humans. So it's not like, they kill them. It's not even like they kill themselves. There's some like back and forth about even how that should happen. It varies how that should happen in these particular contexts in the Arctic and subarctic. In other societies, people who may be seen as a burden, and who have low reproductive potential, they don't exhibit suicidality. They actually will coerce their kin into giving them, like, they're like, no, you give me resources. Like, and it's like, oh, what, would I be better off dead? And it's sort of framed like that, but it's, it's actually coercive. It's like, well, you should give me resources. And we do see in societies that people will stop giving resources to older, elderly, because life is harsh. And so when someone is sick and older, sometimes they will just sort of slowly relinquish resources, sort of quietly, and not drawing attention to themselves or the situation. And eventually the person will like slowly pass away. And then, but that's also not, so that sort of goes against the inclusive fitness model, because if we have this adaptation, we wouldn't really be seeing that. We would be seeing death, It doesn't, how does that benefit the group to slowly pass on? It should be sort of a quick decision, right? So it just doesn't look like there's a mechanism for suicide death when an individual has low reproductive potential and is, not contributing to the group. The other thing about that is, and so on the surface, it seems like, oh, okay, well, suicide death tends to increase with age. We see that cross-nationally. But it's not like as you get older. It's actually, I think it peaks for males sometimes in the 50s or 60s. So actually when their reproductive life is sort of at the end, but they're not in their 80s and 90s, when you'd expect like, more health issues, for instance. But the cross-national data doesn't reflect, data in smaller societies that just that data just doesn't make it into the cross-national data sets. So for Pacific Islanders, they, like in Micronesia, for instance, it's young men. It's men who are 15 to 25. In Turkey, it's young women. So it's people, and actually, so setting aside suicide death and just talking about suicidal ideation and attempts, actually the data show it's young people. It's people who are 15 to 30 at the peak of their reproductive life. And so that does not make any sense at all from the inclusive fitness model perspective, because attempts should be associated with, and also just the fact that people are so bad at killing themselves, which is a weird thing to say, but it just looks like that's a very difficult, that self-preservation is not something humans overcome. And in fact, in many instances, it looks like when people do die by suicide, it's because of, it seems so stochastic, first of all. So there's some randomness involved, perhaps related to, the randomness of you have to send a signal with some probability of actual death. That's the signal. And so some people, because of the nature of that signal, it's a true risk. Some people will die. And that's just a risk that people have to be willing to take if they perceive their fitness as being low. So there is going to be some stochasticity, we'd predict. It looks like firearms are associated with increased risk of suicide death. So actually they have like data in California, it came out, I think last year. So just having a firearm, so even just like ruling out what the people who went out and bought a firearm in order to die by suicide, it seems that having a firearm increases your risk of suicide because it's a novel technology, it's highly lethal. And so, our brains are just maybe not, you can make a snap impulsive judgment that can result in instantaneous death. And that's not something that necessarily would have been around. That technology wasn't around for most of human history. Yeah. And so, there's a lot going on, but most of the time, the vast majority of time. So and even I have to remind myself, it's like, you can think of like, well, what about people who jump in front of trains? What about people who, there's lots of highly lethal methods, but the vast majority of time, the methods have pretty low lethality.
Do we have higher rates of suicide in modern industrialized societies than in traditional ones?
So it's hard to get good numbers on traditional societies, just because the longitudinal data isn't really there. There'd have to be people kind of collecting that data year after year, and sometimes it's hard to access these societies. There's, not great record keeping. In some parts of the world, it looks like in many places, many cultures in Papua New Guinea, they have extremely high suicide rates, higher than I think what you would find in the U.S. And high suicide attempt rates. But it's hard to say, and you'd also expect there'd probably be quite a bit of variation depending on, the social dynamics of those societies, like who is likely to be powerless, what are the dynamics of power in those societies, what kind of social threats do people face. So I don't know if we know. I don't think we can really say whether they're higher or lower, but there does seem to be quite a bit of variation.
And what about some specific countries like Japan? Because it seems that it has very high suicide rates, at least comparatively high.
Yeah, it's really hard to say. Like Japan has really high rates, India, Greenland, where I work in Micronesia, they have pretty high rates. And sometimes that's fluctuating too, and it's not always clear why. So I wish I knew. I wish I did know why. It's something sociologists, I mean, that's, Emile Durkheim, he was trying to tackle that, he introduced the field of sociology with that very question. And people are still asking that question. So there, some people like Durkheim's work. I think there's something to it, the idea that some people are overly regulated by society. Some people aren't integrated enough into society. I think we do see that, because both of those can result in fitness threats. So if you lack a social group, that is a fitness threat in and of itself. You need a group to help you find a mate. You need a group to help you raise your children. And if you don't have that, that is a fitness threat. If you're being overly controlled by your kin, which seems to be the case perhaps in East Asia, also in Pakistan and much of the Muslim world, where they seem to, on paper, they seem to have low rates of suicide, but that might not be true. People are they are forced to do things that don't benefit them because of conflicts of interest between family members, reproductive interests often. And so, yeah, I wish I could give you a better answer, but yeah, it's something people are still asking that question.
Yeah, fair enough. Can people resort to suicide as a form of apology?
I came up with that idea, suicide as a costly signal of apology, or suicidality as a costly signal of apology, because when we went through the ethnographic work, so Ed Hagen, he was my PhD advisor, and he developed the bargaining model and originally applied it to depression, but then also applied it to he was making sense of the ethnographic literature, where it seems to be, sending a signal to not be forced into a marriage, or that you are in need of help. And then the costly apology. So after I, read all of the cases, I went to him and I was like, we're finding evidence for the bargaining model, but there are these other cases that are sort of opposite. So from the original formulation of the bargaining model, it's that the suicidal person is being harmed by others. So it's sort of like, where's the wrong, you might say. So they're being harmed by others, and they need to communicate that they're being harmed. But in some examples, in a subset, it looked like the individual who was suicidal had done something wrong to others. So they had committed some kind of sin or crime or transgression that, and then that did result in some sort of sanctions or punishment. And that didn't really fit with the original bargaining model, which framed the suicidal person as more of a victim. In this case, in these examples, it looked like the suicidal person was more of a perpetrator. And so it's really just a reformulation. And also, like, why would a suicidal person, if they're being harmed by others, why would they feel shame and guilt? It didn't really fit. And so I developed the costly apology model to sort of make sense of that, to signal, in situations where someone has committed a transgression that they can't directly compensate for. So if you steal someone's resources, you can compensate by giving them back or just replacing them. If you accidentally kill somebody, if you do something you can't undo, maybe a sexual transgression, something you can't undo, you might have to send a different type of signal. And we do see across societies that costly signals often involve non-transferable. It's not like a transferable good. So among the Ainu of Japan, for instance, they'll be forced to shave their hair and beard if they did some kind of wrong. It's sort of they have to live in some kind of shame for a little bit, or some kind of be stigmatized for a little bit. And then afterwards, that makes up for their crime or sin. And so it's sort of, applying that to, suicidality. Maybe it's sending an honest signal of, I can't replace the goods, but I'm so, this is how sorry I am, that you're willing to take your own life because you find that life isn't, worth living anymore without the group. And then others can respond to that signal. And so I've been thinking about it a lot because, it's not really, so yes, it looks like it does happen. It sort of is like the question of, what does suicide mean? What does suicidality mean? What does the signal mean to people? And so these slightly different contexts, it could produce, maybe suicidality does mean different things, but really the bargaining model and the costly apology model are really the same. It's sending a signal of, how much you value your circumstances. And so in the context of feeling guilt or shame for something you've done for harming others, people can recognize that as that person is really sorry, and maybe we can reintegrate them into the group. And then, similar to, saying I genuinely don't want to be involved in this forced marriage, people change their behavior. So it's really about sending a signal for how much you value your circumstances, and then others changing their behavior.
Mm-hmm. So we've talked a lot about evolutionary approaches to suicide. Do you think that suicidologists in general are lacking these kinds of tools that come from evolutionary theory in order to understand suicide and perhaps also prevent it?
Yeah, well, the field of, or the area of suicide prevention in the Western world is really politicized, and not in the Republicans versus Democrats kind of political. It's you just can't say certain things. So the bargaining model is really not okay from those perspectives. You can't say that. You have to. Actually, the media guidelines, in fact, say you can't talk about, and this is really crazy, you can't talk about the causes of suicide in publication.
Really?
Yeah. It sounds like I'm making this up because it's so ridiculous. But the American Foundation of Suicide Prevention, so it's talking about LGBTQ youth, you can't say there's a pandemic of suicide among transgender youth or LGBTQ youth, because maybe people will identify with that and then feel like they have to. This is all speculation, by the way. There's no data to back this up. It's just speculation. Maybe people will identify with the suicide epidemic and then that'll cause them to behave, to self-harm or attempt suicide. Um, you also can't link it to like specific events. You can't say it's caused, you're not allowed to say it's caused by one thing. You have to say it's caused by a myriad of circumstances, including mental illness, which is entirely circular because it's like a lot of, suicidality is a symptom of mental illness, but it's also caused by adversity, as many mental illnesses are. And so, but you can't just, so that's just an entirely circular thing to say that it's mental illness and not a rational response to circumstances, or you can't say that suicide achieves goals, which is sort of what an evolutionary perspective is saying, that it's, because it's not about the conscious, like, this person is engaging in suicide to achieve X. It's, much of it could very well be unconscious. Like, many times people attempt suicide without, like, quite impulsively, without even thinking about why they're doing what they're doing. It's just something is going on right in that moment. And so the whole thing is ludicrous. So it's like, in order to prevent suicide, we can't talk about what causes suicide, which is what it looks like. And so that's just a mess. I don't know. I don't, yeah, that's the way it is.
I mean, that's really weird. So, how can we prevent suicide without talking about its causes? At
Um,
least for me, it seems contradictory, I guess.
yeah, I mean, so it's a really diverse field, and it's not that everyone who studies, so the people who study suicide, or suicidologists or who study suicide are pretty diverse. Not everyone agrees with that, with, those guidelines. But obviously there's, some powerful people do. There's perhaps a majority who do. Um, yeah, I don't know what people are. I mean, I think the other issue is, so that's one issue. Another issue is that we, because we're in the Western world, most of our data is coming from, I don't think they have read the Joe Henrich's like weird paper. A lot of the data comes from the Western world, urbanized settings. So even if they're in non-Western setting, they tend to be urbanized settings. There's not really an appreciation for, maybe they appreciate it, but it's not considered really valuable to have data from small scale societies. Maybe they think it's, not very relevant to the modern world. And another thing is that they're really interested, it's all framed in terms of the mind much of the time. I mean, so there's sociologists, and actually my work, on the bargaining model and these cross-cultural perspectives, it does overlap with some sociological perspectives. So just a work influenced by, I think his name is Ian Black, and its framing is quite different, but the gist. But if you kind of get past the language and the terminology, at the heart of it, it's really the same. It's about powerlessness and asymmetries in power and how people like can achieve ends. And so there's a lot. It seems like there are some people who are kind of talking about the same thing, but they're in different fields or in different sorts of social sciences. There are a lot of people who do talk about the social circumstances of suicide. But yeah, it just doesn't seem to influence, because it's really the psychologists who rule suicidology. Like Thomas Joyner's work is really influential because it just fits with the way people have been thinking about suicide. Like when I told people I was doing research on suicide as an anthropologist, they were like, some people are like, why would you do that? You're an anthropologist. And I'm like, why so? Like, I didn't really get what they meant. But yeah, there's this perception that suicidal behavior is caused by something going on in the person's brain, something in their mind, something internal to the person. And that maybe it matters what's going on in the outside, but it's really how they interpret and manage their own mind. That seems to be the general perspective in psychology, as well as within the general public who sees suicide as a issue for psychologists to deal with. Because that's also like who you go to if you are feeling suicidal, or people, or if your family member is, you would send them to a psychologist or a psychiatrist, a mind brain doctor. And it matters less, it seems to matter less to people what's going on in the social world. And that could just be a bias of, being Westerners and being individualists.
Mm-hmm. So I have here 2 or 3 more general questions. So when it comes to mental disease in general, and looking at the relationship between mental health professionals and their patients, is there a power imbalance there? And if so, what are the kinds of implications that it would have?
Yeah, well, there's certainly any sort of therapist, whether they're like a counselor, clinical psychologist, or psychiatrist, there's absolutely an imbalance of power, no matter which like kind of field or school you're into. If you're a patient, that's the doctor or specialist patient relationship. There's absolutely an imbalance of power because the one person is believed to be knowledgeable, has a certain skill set and a certain level of education. And actually, maybe it varies. Maybe there are settings where a psychiatrist is working with a high-powered politician, and maybe it's reversed. But I think the vast majority of the time, whoever that person is probably has more education than their patient, or they have the knowledge that the other person is trying to extract from them, to help them. So the patient is in need, and there's the specialist. And there's nothing wrong with that. Now there are like and this is a body of work I hope to look into more, because I haven't read too much on the counseling literature side, but there have, in discussions with people who are counselors, there are apparently therapists who believe that the power dynamic isn't real, or that it can be easily overcome, which I think is really naive. Because, and also like I've just talked to people who have just been really, I guess they would call it invalidated by that setting, because they're trying to express their need, but it's not falling within a certain narrative that the counselor or the psychologist or the psychiatrist is willing to buy. And so they felt like, they were overlooked or not understood. So, with regards to the fact that, well, psychiatrists are the ones, as a body, as a field, they develop the terminology that classifies mental illness, which is, in our day and age, it's an identity to some people. Now, not everyone, some people really take on, like, I'm depressed, or I'm autistic, I'm on the spectrum, or I have ADHD. They really like own that, I guess they try to take power back, because it's still to some extent stigmatized. And other people don't own that so much. But recently, there was a Twitter thread I thought was really interesting, because I was like just perusing through it, and it was sort of like talk about a negative experience in therapy, because it's not all happiness and sunshine necessarily. And what I saw was people were just having it was a negotiation for identity and validation. So there were a lot of people who were, they wanted to get that label, right? Maybe they thought they were ADHD and they wanted to get confirmation that they were, and they really had to push for that. I think autism came up a lot. There were people who were really pushing, like, no, I'm autistic, and they sort of had to convince people about what they were. Others, and that's interesting. I mean, that's interesting in and of itself, because there's that sort of like subjectivity aspect to, how can you tell if you're what? Because it's all subjective. Gosh, there are other examples. But yeah, negotiations or the other one was just having different therapists tell them that they have low agreement between different psychologists or psychiatrists about what condition that person has, and getting prescribed different medications and having horrible side effects, because like antipsychotics, for instance, have really, horrible they can have really horrible drastic side effects. You can gain weight, you can have metabolic disorder. It can result in I think you're at an increased risk of heart attack. Even antidepressants have, undesirable side effects, so you have to weigh the costs and benefits. And so people who are going in feeling helpless, needing help in their lives, I guess from there, it seems like, wow, it's even more out of control, because the people in power who are supposed to tell me who I am and, are supposed to treat me can't even agree. And I'm sort of getting these different medications, and it's just, until eventually someone gives them a diagnosis that fits and a medication and a treatment program that fits. So it's I just find that, that fascinating, because, I think maybe that's a new phenomenon, because in the past, people would say the psychiatrist, you would just trust what the psychiatrist says and accept his treatment. Whereas it seems like now it's a little bit more of a negotiation. So maybe patients are feeling more empowered to speak up for themselves. Nevertheless, it's still the person writing prescriptions. It's the person who, decides whether their condition is going to be reimbursed by their insurance. That's, the doctor, the specialist, still has that power.
Mm-hmm. And I guess that not only that, but mental health professionals also, at least to some extent, shape public discourse on how people think about these mental disorders and the culture that develops around them, right?
Yeah, and so, suicidality, depression, anxiety, because it looks like, especially for suicidality and depression, a lot of those conditions are already associated with power asymmetries, in which the person who's depressed or suicidal is lower in power. And so it's interesting because, we're a society, most people like power, or they admire people who have power. Maybe we think we stick up for the powerless, but generally we don't, because it's a lot easier, most of the time, it's a lot easier to decide with the person who has power, because they might harm you, or it's just an uphill battle, or, you have to swim against the stream, basically. That's where the might, the actual, there could be real world consequences to fighting against the system. And so, just for instance, the whole Me Too movement, it turned out a lot of these men in power were, probably no surprise from any evolutionary psychologist, they were abusing their power to gain sexual access to women who were lower in power and maybe didn't feel like they could escape those situations. That's one, and that is also one of the leading risk factors for suicidality and depression, is that very power dynamic. And so it's interesting that these sort of low power strategies from an evolutionary perspective are classified as diseases, according to psychiatry.
Mm-hmm. So just one last question. Do you think then that, we've been talking a lot about the anthropology of mental disorders. Do you think that at least certain subfields of anthropology, like, for example, I don't know, biological anthropology, evolutionary anthropology, cultural anthropology, maybe can help us fight against mental disorders, the ones that are most prevalent in modern industrialized societies?
Yeah, well, cultural anthropology is a great example, because cultural anthropologists like to study the powerless. And I think a lot of times, the marginal, the powerless, and a lot of times they end up writing about, depression or suicidality or stress without even necessarily meaning to think about it in the DSM category sort of way. But when you work with different groups who are, if you work in the Pacific Islands, for instance, because of the loss of culture and because of colonization, if you work there, you're going to come across, substance abuse. You're going to come across behaviors that would be classified as a DSM category. And so people can end up writing about those things without even realizing or consciously, looking for them from the Western biomedical perspective. So I think, yes, and then of course the problem is that the people in the medical profession don't even know it's there because they don't know to look for it. So I definitely think, I think it's cultural anthropologists, evolutionary psychiatrists are different because they have, the medical perspective, but maybe less so the cross-cultural perspective. And so it is just about bridging these different fields and getting people to come together and say, to agree that this is something important and to work together to have like to come to a shared outlook. And I think that is happening. I think it's just happening very, very slowly, incrementally. But I hope it continues down that way. We'll see.
Mm-hmm. Yeah. Okay, so let's end on that positive note. Just before we go, where can people find you on the internet?
So I'm on Twitter, Kristen Syme. Dang, I still have to get my webpage up. That is on my to-do list. Eventually I'll have a webpage. But not at the moment.
Okay, so I will be leaving some links to your work in the description box of the interview. And Dr. Syme, again, thank you so much for taking the time to come on the show.
Of course. Thanks, Ricardo.
Hello, everybody. Thank you for watching this interview until the end. So it is thanks to people like you that the show has been running for such a long time, more than 3 years now. And I would like to ask you to please pay a visit to my Patreon page and to consider making a pledge there. If you prefer PayPal, you can also find links to it in the description box of the interview. Otherwise, and if you like what I'm doing, please share the interview, leave a like, hit the subscription button, and comment on it. This show is brought to you by Enlights, Learning and Development Done Differently. Check their website at enlights.com. I would also like to give a huge thank you to my main patrons and PayPal supporters, Karin Litska, Anne Blanchett, Pererga Larsen, Lau Guerrero, Francis Ford, Hans Frederick Sunder, Ricardo Vladimiro, Craig Healy, Adam Castle, Olaf Alex, Jonathan Wiesel, Jacob Klinkby, Matthew Whiting, Bernardo Wolf, Tim Hollis, Henrik Alenius, John Connors, Paulina Barron, Philip Force Connolly, Jerry Mueller, Herbert Gintis, Rutger Bosch, Bo Weingart, Becca Newberger Goldstein, Dan Demetrio, Robert Windecker, Rui Inácio, Arthur Coe, Zoop, Marco Neves, Colin Holbrook, Susan Pinker, Thomas Trumbull, Bernardo Seixas, Pablo Santurbano, Simon Columbus, George Pinha, Phil Kavanagh, Corey Clark, Mark Blythe, Roberto Inguanzo, Michael Stormir, Eric Neumann, Samuel Andreev, Tiago Nunes, Bernard Ugni, Alexander Dunbauer, Omari Hickson, Fergal Cusson, Evan Bodrenko, Ala Herzog, Don Ross, Jonathan Librand, Oslam Bullet, Nathan Nguyen, Stanton T, Samuel Correa, Eric Hines, Mark Smith, J.W., João Eira, Tom Hummel, David Sloan Wilson, Yacila Dez Araújo, Eden Solan, Romain Roach, Dmitry Grigoriev, Diego Londoño Correa, Tom Roth, Yannick Punter, Adana Rusmani, Charlotte Bliss, Miran B, Nicole Barbaro, Adam Hunt, Pavel Ostazewski, Max Bailby, Nelek Bach, Catherine and Patrick Tobin, Al Ortiz, Guy Madison, Gary G. Elman, my producers, Isar Webb, Jim Frank, Lucas Stafiniak, Ian Gilligan, Sergio Codriano, Luís Caetano, Tom Van Egdam, Curtis Dixon, João Linhares, Benedict Mueller, Vega Guidi, Sardas France, and Niruban Balachandran, and my executive producers, Michelle Rugieski, Rosie, James Pratt, and Matthew Lavender. Thank you for all.